Welcome to the deep dive. Today, we're diving into the world of autoimmune diseases, but we're making it even more intense. We're focusing on how these conditions, these tricky conditions show up in the ICU. You know, that place where every second counts.
Absolutely.
Now, you wouldn't be here if you weren't already kind of ahead of the curve on this topic. Maybe you're a medical pro, maybe it's personal, or maybe you just love a good medical mystery. Whatever brought you here, get ready for some serious knowledge because we're about to break this down. And let's be real, this is some next level stuff. That's why I'm so pumped to have our expert here to guide us through this.
Happy to be here.
They've got this amazing ability to take the densest medical research and turn it into like aha moments, which is exactly what we want on the deep dive.
It's always exciting to delve into these intricate areas of medicine.
So picture this, someone lands in the ICU. Organs on the Fritz alarms blaring, and the medical team is racing against the clock. They're running every test imaginable. But the cause is a total head-scratcher. Turns out it's an autoimmune disease silently wreaking havoc. Talk about an invisible enemy.
Oh, yeah.
And the research paints a pretty stark picture here.
Yeah.
Up to 1 in 10 people are living with an autoimmune disease. And while treatments have come a long way, for some it's a ticking time bomb. 10% of those patients end up critically ill because of it. So that's where this deep dive gets really important. Early identification can be the difference between life and death in the ICU.
Absolutely. Those early, often subtle symptoms, the fatigue, the low-grade fever, the unexplained weight loss, those are crucial pieces of the puzzle. In the ICU, we don't always have the luxury of time to wait and see. So recognizing those early warning signs can be life-saving.
So it's like noticing the small crack in the dam before the whole thing bursts.
Precisely. And that's just the first hurdle. Treating autoimmune diseases in the ICU is a high-wire act. You're trying to rein in the immune system without completely shutting it down and leaving the patient vulnerable to a whole host of other problems, especially infections, which are already a major concern in the ICU.
It's like trying to disarm a bomb. You have to be incredibly careful not to set it off in the process.
That's a great analogy. It requires a deep understanding of the intricacies of the immune system, the specific disease process, and the potential complications. It's not just about knowing the right treatment, it's about knowing when and how to use it.
And that's where having a skilled and knowledgeable medical team becomes absolutely critical. So let's meet some of these autoimmune troublemakers. The research calls them the usual suspects of the ICU. And trust me, some of these are like the notorious villains of the medical world. They can be really good at hiding in plain sight.
It's true, they can be quite the elusive bunch. But like any good detective, we've got our methods for tracking them down.
Okay, first on the lineup, we've got the connective tissue diseases. What are we dealing with here? Is it like having faulty building blocks for your body?
That's a great way to think about it. Connective tissue is like the scaffolding that holds everything together. And these diseases, they disrupt that scaffolding, causing the immune system to attack your body's own structure.
And this category includes some big names, right? Like lupus or SLE, as it's known in the medical world, scleroderma and myositis.
Yes, exactly. Each with its own personality, so to speak, but all united by this theme of the immune system, targeting those vital connective tissues.
Next up, we have vasculitis. What's the story with this one?
Imagine your blood vessels as a network of highways, transporting vital supplies throughout your body. Vasculitis is like setting up roadblocks and detours on those highways, disrupting the smooth flow of traffic.
And if those highways are blocked or damaged, things start to go wrong. That's when we see organ damage, right?
Precisely. And the severity depends on which highways are affected and how widespread that disruption is.
Now, our research mentioned 2 main types of vasculitis, ANCA-associated and immune complex-mediated. Let's break those down. ANCA-associated sounds a bit like a secret society.
It does, doesn't it? ANCA stands for anti-neutrophil cytoplasmic antibody. These antibodies target specific proteins in neutrophils, which are a type of white blood cell.
So it's like an internal battle with antibodies going after your own white blood cells.
Exactly. And this battle can have major consequences because it can trigger inflammation in the blood vessels, leading to all sorts of problems depending on which organs are affected.
And what about immune complex-mediated vasculitis? That sounds like something straight out of a medical thriller.
It's all about these things called immune complexes, which are like clumps of antibodies and antigens bound together. Think of them as debris clogging up the works. In this type of vasculitis, these immune complexes get stuck in the walls of blood vessels, causing inflammation and damage.
So we've covered the connective tissue attackers and the blood vessel disruptors. What other autoimmune troublemakers are on our list? Our research also mentions sarcoidosis and adult-onset Still's disease.
Good catch.
Yeah.
These are less common than the others, but they're important to know about because they can be real wildcards in the ICU.
Sarcoidosis always sounds so mysterious to me. What exactly is going on there?
It's almost like the body decides to play a prank on itself. Sarcoidosis involves the growth of tiny collections of inflammatory cells, called granulomas, in various parts of the body,
So it's like these little inflammatory parties popping up wherever they please.
pretty much. And the guest list isn't always predictable. The lungs are a popular spot for these granulomas to hang out, but they can also appear in the lymph nodes, skin, eyes, and other organs.
And adult onset Still's disease? That sounds like something you wouldn't want to mess with.
It's definitely one of the more dramatic presentations in the autoimmune world. Imagine high spiking fevers, a rash that appears and disappears like a magic trick, and joint pain that comes and goes. That's adult onset Still's disease in a nutshell.
High fevers, disappearing rashes, and achy joints. That's a triple threat I could definitely do without.
And to make matters even trickier, it can mimic other conditions, making a swift diagnosis a real challenge.
Okay, so we've got our lineup of usual suspects, each with its own unique way of wreaking havoc. But recognizing them is just the first step, right? What happens when an autoimmune disease is suspected in the ICU? Is it like hitting the panic button?
Not quite panic, but definitely a call to action. Remember, in the ICU, we're often dealing with a ticking clock. The sooner we can identify the culprit and initiate appropriate treatment, the better the chances of a positive outcome for the patient.
So how do doctors even begin to piece together this puzzle? What are some of the red flags that send up those warning signals?
The patient's medical history is crucial.
Mm-hmm.
Do they have those vague symptoms we discussed earlier? Fatigue, low-grade fever, weight loss
Mm-hmm.
in the weeks or months leading up to the ICU admission? Those seemingly insignificant details can be major clues.
So it's like piecing together a trail of breadcrumbs that might lead back to the source of the problem.
Exactly. And then there's the pattern of organ dysfunction. If we see multiple organ systems involved, lungs, kidneys, heart, nervous system, that's a major red flag. That's something more systemic, like an autoimmune process might be at play.
It's like that game Clue, but instead of Colonel Mustard in the library with a candlestick,
Yeah.
it's an overactive immune system attacking the lungs with inflammation.
You got it.
Now, I know we often think of blood tests and scans as the be-all and end-all in medicine, but our research suggests that even these can be misleading when it comes to diagnosing autoimmune diseases in the ICU.
You're right. It's not always as straightforward as we'd like. Take antibody testing, for example. We often look for specific antibodies as a marker of autoimmune disease, but sometimes those antibodies can be present, even when the disease isn't currently active. It could be a sign of a past exposure or a dormant condition.
So you could have the antibodies without the disease actually causing problems. That's wild.
It is, and on the flip side, sometimes the disease is active, causing all sorts of havoc, but the antibody levels haven't increased enough to be detected yet.
So it's like trying to catch a shadow. It's there 1 minute and gone the next.
Precisely. That's why it's so important to interpret test results within the context of the patient's overall clinical picture, their history, and the pattern of their symptoms. It's about connecting the dots, not just relying on a single piece of information.
So it sounds like diagnosing an autoimmune disease in the ICU is a bit like trying to solve a Rubik's Cube while riding a roller coaster. You've got all these moving parts and you have to think fast to figure out the solution.
That's a great way to put it. And just like with the Rubik's Cube, there's no one-size-fits-all solution. Each case is unique, and it takes a skilled clinician to navigate the complexities and make those crucial decisions.
Okay, so let's say after all that detective work, a doctor in the ICU is pretty sure they're dealing with an autoimmune disease. What happens next? How do you treat something that's basically your own body waging war on itself?
That's the million-dollar question, isn't it? And it's not as simple as just hitting a pause button on the immune system.
Right, because you still need your immune system to fight off all the other nasty bugs and viruses lurking around, especially in a place like the ICU.
Exactly. It's about finding that delicate balance, calming the immune system's attack without leaving the patient completely defenseless.
So it's like trying to reason with an overzealous security guard. You want them to chill out, but you still need them to do their job to some extent.
I like that analogy. And often the first step in this delicate dance is using corticosteroids.
Ah, corticosteroids. Those are the heavy hitters of the anti-inflammatory world, right?
That's right. They work quickly to reduce inflammation and suppress the immune response, which is why they're often the go-to in a crisis. But like any powerful tool, they come with potential side effects, especially with long-term use.
So they're like the emergency brake, effective but not a long-term solution. What other options are there when corticosteroids aren't enough, or when we need to start thinking long-term?
That's when things get really interesting.
Uh,
We might consider cytotoxic drugs, which work by slowing down the growth of immune cells.
So instead of a full-on stop, it's more like tapping the brakes on the immune system's activity.
Yes, that's a good way to
Yay.
think about it. And then we have these amazing new tools called biologics.
Biologics, that sounds high-tech. What are those all about?
They're like guided missiles for the immune system. Biologics are engineered antibodies designed to target very specific parts of the immune response, blocking those pathways that are causing the trouble.
So instead of a sledgehammer to the entire immune system, it's like using a scalpel to target the problem areas with incredible precision. Exactly. It's a really exciting area of medicine, and it's constantly evolving with new discoveries and advancements.
This is blowing my mind. It's like we're witnessing a revolution in how we understand and treat autoimmune diseases. But I imagine with all these treatment options, it's not a one-size-fits-all situation.
You're absolutely right. That's why having a skilled medical team is so crucial. They're the ones who can assess each patient's unique situation, weigh the risks and benefits of different treatments, and tailor the approach for the best possible outcome.
It's like they're crafting a personalized strategy for each patient, taking into account all the factors at play.
Precisely. And timing plays a huge role, especially in the ICU.
Makes sense. The faster you can intervene, the less damage the immune system can inflict. Exactly. It's all about damage control and giving the body the best chance to recover.
Speaking of recovery, our research suggests that even when treatment is successful in calming down an autoimmune flare-up, the story isn't necessarily over. There's still the risk of infections, right?
Unfortunately, yes. Suppressing the immune system even in a controlled way is like lowering the drawbridge to the castle. It makes the body more vulnerable to invaders, especially those opportunistic infections just waiting for a chance to strike.
So it's like winning one battle, but the war isn't over yet.
In a way, yes.
Yeah.
And these aren't just your common colds either. We're talking about potentially serious infections that can be much harder to fight off when the immune system isn't at full strength.
Are there any particular infections that tend to be more common or dangerous in this context?
Our research specifically mentions strongyloidiasis, which is a parasitic infection. It's more commonly found in tropical regions, but it can be incredibly dangerous, even deadly, if it takes hold in someone with a suppressed immune system.
Wow, that's a sobering thought. It highlights the importance of being aware of even those less common infections, especially in people with weakened immune systems.
Absolutely.
Hmm.
And then there's pneumocystis pneumonia, or PCP, which is a fungal infection that can be particularly dangerous for those on immunosuppressant drugs.
A fungal infection? That's not something you hear about every day.
It's more common than you might think, and it's one of those infections that we're always on the lookout for in patients with compromised immune systems.
This has been an incredible deep dive. We've covered so much ground, from recognizing those early warning signs to navigating the complexities of treatment and managing the ongoing risks. It's clear that we've made incredible strides in our understanding of autoimmune diseases, but there's still so much more to learn.
Absolutely. One of the biggest questions is simply how prevalent autoimmune diseases are in the ICU. Diagnosis can be tricky, and it's likely that many cases are missed or misdiagnosed. Until we have a clearer picture of the true scope of the problem, it's hard to know where to focus our efforts.
And if you don't know how big the problem is, it's hard to allocate resources for research and treatment.
Exactly. We need more research, more data, and more awareness to effectively tackle this challenge. And of course, one of the biggest goals is to move beyond a one-size-fits-all approach to treatment. Personalized medicine, where we can tailor treatments to each patient's unique immune system and disease profile, is the future.
Imagine a world where we could predict which patients are most at risk of developing these complications, intervene early with targeted therapies, and minimize those long-term consequences.
That's the dream. And I truly believe that with continued research and a commitment to innovation, we can make that dream a reality.
This deep dive has been truly eye-opening. A huge thank you to our expert for shedding light on this complex and often overlooked area of medicine. And to you, our listener, thank you for joining us on this journey of discovery. We hope you've gained some valuable insights that will help you navigate the world of autoimmune diseases. Remember, knowledge is power, and the more you know, the better equipped you'll be to advocate for yourself or your loved ones. Until next time, keep asking questions and stay curious.